I'm Judy Gooding, Senior Advisor at the National Institute for Children's Health Quality, and I'm Project Director for this initiative, which is funded by the Patient-Centered Outcomes Research Institute. That's PCORI. Today's webinar, Lens Care, Leading Equity Now in Systems of Care Before, During, and After COVID, is led by Renee Kennedy, whom I'll be introducing in just a few moments. This session is part of an enhancement support to NICHQ's PCORI-funded project that began in 2019. The original project brings attention and solutions to missed sickle cell disease appointments. In this enhancement, NICHQ is focusing on the impact of COVID-19 on children with special healthcare needs and families experiencing racism in U.S. healthcare systems, which we know has been exacerbated by the pandemic. I want to thank PCORI for the grant that supports this project, and I want to recognize our project officer, Courtney Clyett, for her work with us and for joining our webinar today. This is the first of two webinars in this COVID-19 enhancement project. And if you haven't already registered for our webinar coming up on December 3rd with Dr. James McElligott, I encourage you to do that. And we'll be sharing more information about that at the end of this session. Now, before we jump in, I'm going to just quickly introduce you to NICHQ, as some of you may not be as familiar with who we are and what we do. For over 20 years, we have focused solely on driving dramatic changes in the complex issues facing children's health. We've led more than 100 initiatives in over 20 health topics, with a focus on executing and scaling systems change to improve children's health and address—
Judy, I believe you're muted.
—disparities. Can others hear me?
Yes.
Okay, thank you. To improve children's health and address disparities, we have a concerted effort around improving the care of children with special healthcare needs, and our webinar today reflects that. At the heart of what motivates us is the belief that children and families deserve better systems and supports so that every child achieves their optimal health. To get us started, I'm pleased to introduce NICHQ's Chief Executive Officer, Dr. Scott Burns, to share our philosophy and focus around the children with special healthcare needs. Dr. Burns is a board-certified pediatrician with expertise in quality improvement in maternal and child health. He's chair of the Progeria Research Foundation and is current chair of the Rare Disease Advisory Panel for the Patient-Centered Outcomes Research Institute. Dr. Burns joined NICHQ as CEO 5 years ago and has led the organization's expanding focus on making sure every child gets quality care that they need, and has led NICHQ to boldly tackle racism and its ingrained impact in child health care systems. Dr. Burns.
Thanks, Judy. NICHQ has made a strong and enduring commitment to combating racism and bias in our health system. Our commitment is focused on children's health care and, more holistically, the family and community that we wish to support that surround each child. Right now, we're especially concerned about the following threats to children: the threat of COVID-19 on vulnerable children and their families, especially kids with special health care needs who may be more vulnerable to the coronavirus or who may not get the virus itself, but may have insurmountable challenges in getting the care that they need. The threat of the long-term impact on children with special health care needs and on all children, impact from isolation, remote learning, disconnection, and fear. And the threat of racism is hurting this country's children and families' chances for optimal health, the subject of today's webinar. Judy Gooding mentioned that our funding for these webinars is from the Patient-Centered Outcomes Research Institute. I want to thank our supporters at PCORI for the opportunity to discuss and begin to address these threats through this project. While NICHQ has had or created the opportunity to address bias in healthcare in much of our work, this project is our first to focus specifically on children and youth with special healthcare needs. Judy?
Our primary presenters today, well, first meet our expert faculty, and I'll introduce them to you. Our primary presenters of our today for this webinar is Dr. Renee Kennedy. She is CEO of the Michigan Public Health Institute, and she's one of our 3 expert faculty for this project. Dr. Kennedy is contributing her expertise in health equity and institutional racism to this work. As a public health advocate, researcher, educator, and facilitator, Dr. Kennedy has published and presented broadly on the topics of health inequities and disparities, the impact of racism and bias in healthcare, on cultural competence, and on social justice. Dr. Kennedy was recently appointed by the governor of Michigan to serve as a member of the state's task force on racial disparities. Dr. Kennedy will be joined today by Dr. James McElligott, who is Executive Medical Director for the Medical University of South Carolina Center for Telehealth. And as a practicing pediatrician, he led the formation of the South Carolina Telehealth Alliance, which he currently chairs. Dr. Lee Sanders also is joining us today, bringing expertise in addressing some of the key challenges in pediatric care during the COVID-19 epidemic, primarily via improved messaging. Dr. Sanders is a general pediatrician and associate professor at the Stanford University, where he is chief of the Division of General Pediatrics. I am so pleased to welcome this expert faculty team, bringing their combination of experience in social justice, telehealth, and COVID-19, and particularly in children's health. Over the next hour, we'll address the following objectives. We'll recognize the dual role that COVID-19 plays for Black and Brown children with special healthcare needs by eliminating the pre-existing inequities while also further exacerbating those inequities. We'll recognize and identify bias within your system and yourself. And the third objective is to learn ideas, tools, and resources to affect change on an individual and system level. Throughout the webinar, we'll be inviting your input and your expertise. So please share your comments, your thoughts, and reactions throughout the webinar into the chat box. Make sure that when you chat, you choose to chat to all participants and attendees so that everyone can see your input or your comments. If you have questions for the presenter, please submit them through the webinar Q&A feature. If time permits, questions will be addressed at the end of the webinar, and also we will be answering questions and in writing and sharing those with you following the webinar, especially for any questions that we're not able to get to due to time constraints. To access both of these features, click on the Q&A image or the chat box image on the toolbar at the bottom of your screen. And as a reminder, the recording of this webinar will be shared with everyone after the live event is over. We'll make that available on the NICHQ website. And now I'd like to welcome Dr. Renee Kennedy.
Thank you, Judy. Let's dive right in. So we want to start out engaging you and reminding you that equity work is both head and heart work. It's important what you know, but it's also important what you feel and think about these things that you know. So let's do a feeling assessment. If everyone in the chat would just, oh no, wait, they need their cell phone. Following these instructions, we're going to do a little bit of a word cloud, right? So grab your cell phones and text to NICHQ C876 to 22333. And we want you to just list one word, one affective word that describes how you are feeling right now. Recognizing that there are lots of things happening in our worlds that may be influencing how we're feeling. So let's see where we are as a group. Ready? Mm-hmm. And I see a few of you that may not have access to your cell phones that have typed it into the chat. We appreciate that, seeing motivated, exhausted, excited. Tired's getting kind of big there. Yeah, concerned, uncertain. We are all products of our environment, and we are clearly having a collective experience as a nation and as health and public health professionals right now, for sure. Defeated, wow, that's powerful. Anxious, worried, unfocused. This issue of self-awareness is so critical as you endeavor to advance equity within your systems, as you pick up the baton to lead equity, not later, not next week, not next year, not when COVID ends, but leading equity now in the systems in which you are serving. So powerful. Okay, I think we're still going to see this word cloud growing and changing, and I think we're going to jump on to the next one. I have a lot of information I want to share with you. Consider me your facilitative guide. I want to just guide you through a journey. Much of this you may have heard before, but I can tell you I've never heard these issues of justice and racism. I've heard it a million times, right? And every time it steeps more deeply, it steeps more powerfully. And so I want to invite you to hear things new, perhaps for the first time, but hearing them anew, if not for the first time. And man, we're going to drive right at that feeling of tiredness and see what we can do to energize you some. So at this point, I am going to flip over and share my slides with you. So give me 2 seconds to do that. Let's see here. Great. All right. Okay. So I am a quotable person. I love quotes, and I always seem to bounce back to quotes by the Dr. Martin Luther King Jr. And I want to just open with this quote, which may be familiar to some of you, right? He says, "I have the audacity to believe that peoples everywhere can have 3 meals a day for their bodies, education and culture for their minds, and dignity, equality, and freedom for their spirits." I mean, I just love that his use of the word audacity, right? He just has the nerve to think, you know, are we asking too much to say that people living in this nation can live their lives without hunger, can live their lives educated and their minds stimulated? How about we just have the nerve to do that same thing? And so leading equity at this stage does take a little bit of audacity. And so we think about what I like to call the 4 basic food groups of health, right? We think about what makes us healthy, and we hear these messages, this narrative repeated, right? Eat your vegetables, make sure you're eating a healthy diet, exercise regularly, see your doctor regularly, and more progressively now we say, oh, sleep deprivation is a thing. Make sure you're getting adequate rest. And so we've gotten socialized to think about these things, but we now also know, thanks to the work of places like the World Health Organization, that it's not just about those 4 basic food groups, right? It is, what does the walk around your neighborhood look like? That impacts your health. What does a stroll through your business district entail? Is it welcoming and inviting? Is it abandoned and lonely? What is the view from your backyard? Is it riddled with outdoor air issues, which then threaten indoor air quality, or is it lush and inviting? What does your educational setting look like for your children, for your neighbors? Is it a vibrant, current, LED certified, great HVAC system? Or is it a decades old building where we've not even valued the play, right? The World Health Organization says where we live, work, play, and pray and age is the importance of this context. And I just invite you to look at that basketball court, right? How are we valuing? And what is our home? What is the quality of our homes? We talked a lot about quarantining at home. If you were a college student that had to return to home and you were living in a multi-unit public housing apartment complex like the one on the left, I bet quarantining and social distancing was a lot harder than if you were in a beautifully manicured home. And dare we say, if you had no home at all. And so it's really, really important for us to think about, health is more than the biomedical. And how do all of us impact? And I just want to have the privilege of sharing some quotes from families and moms that have been a part of a research project amongst our faculty. And this quote, a mother of 2 children with special healthcare needs, says, "Another reason getting to appointments can be challenging is because it takes money to travel to and from appointments, especially when you're not on Medicaid. And the travel expenses have to come out of your own pocket. Health insurance for my kids is covered through my employer. I pay out of pocket to put gas in my car. I pay for parking. And because I'm traveling an hour each way after school, my kids are going to be hungry. So I'm paying for food as well. Simply saying, eat your vegetables, exercise, see your doctor, and get rest clearly is not adequate for the messages and the systems that we are structuring." So this is all kind of complicated by context and by various other complications. And so we are now dealing with 2 huge complications. First, the COVID pandemic, the coronavirus pandemic, and we're learning all types of new behaviors, not just eat your vegetables, but understand social distance and follow it. Understand mask wearing, and it doesn't matter if you're a young child, understand those behaviors. And washing hands is taking on a whole new level of importance. And at the same time, we're dealing with the complication of social justice consequences in our nation. Social uprising, protest, both at the systems level in terms of systems like that interact with policing efforts, also at the interpersonal level, what is happening to individuals because of their race, class, or gender. And so it's complex and it's complicated, these contexts in which we're living our lives. And I'm really glad that 2 of my colleagues, Dr. Sanders and Dr. McGillicuddy, are here to also give you some insights on those complexities as well.
Thank you so much, Dr. Kennedy, and huge gratitude to you for not just your words and your thoughts, but your deeds, your leadership in Michigan and nationally on many of these issues. I'm a general pediatrician, like many of you, serving kids with special needs. You can see our children's hospital in the background here, but I care for mainly children in low-income ethnic minority communities with special healthcare needs. And as a general pediatrician, I want to start off with the good news, that while COVID-19 is certainly complicating equity and exacerbating a lot of the pre-existing disparities that Dr. Kennedy just talked about, the direct effect of COVID-19 on children has been fairly mild and surprising to many of us in general pediatrics. The individual cases of COVID-19 are less common among children than among adults. and the individual cases are often much more mild, much less likely to result in hospitalization or death. Next slide, please. Nonetheless, as I mentioned, and as Dr. Kennedy mentioned, the pandemic is unearthing pre-existing disparities. One subgroup of children that is most affected by widened inequities are children with special healthcare needs. These represent nearly 1 in 5 US children with conditions that are often identified at birth and often have a neurocognitive or behavioral component to them. These children are also more likely to live in poverty. Now, about 1 in 5 US children live in poverty, but more frequently, children with special healthcare needs live in poverty. As a result of this, these children are at higher risk of the direct effects of COVID. That is on chronic illness, particularly children with chronic lung and cardiac disease and those with technology dependence, but also at the household level. We know that children with special healthcare needs are more likely to live in households with caregivers who themselves have a chronic illness or themselves are essential workers that are greater direct risk of the virus. But most immediately, what we are seeing in our primary care practices are the increased needs for social services made apparent by the indirect effects of the virus, the increased need for mental and behavioral health services, the increased food insecurity, the increased need for attention to social and emotional learning, as well as special education needs that are harder to address because of all the distance learning that these children have had to face. And as a result, we have a number of widened inequities that we're experiencing on our watch. And these inequities are clearly more drastically affecting communities of color. In this graph from the CDC from midsummer, we can see that even the direct effects, the hospitalization rates for COVID were much more common across the age groups in communities of color, Hispanic or Black communities. And as a result of all of this, we're seeing a tension that's being exacerbated by this pandemic, and that's drawing out the layered effects of these inequities that Dr. Kennedy has so well pointed out. At an individual level, we see increased rates of anxiety and depression, concerns about learning loss and achievement loss, and widened achievement gaps, particularly in our public schools, childcare and financial insecurity, and the food insecurity I mentioned before. Now, I happen to be in Silicon Valley, and so everybody out here thinks that technology is the solution to this. Before I pass this over to Dr. McElligott, however, as a health disparities researcher, we also know that anytime a new disparity is introduced, it normally increases disparities. Nonetheless, Dr. Kennedy pointed out from that quote before that it's very expensive for families to bring their children into the clinic. So it's our hope that some technologies such as telehealth might be a portal through which we can reduce and address some of these disparities. Dr. McElligott? I think you're still on mute, Dr. McElligott.
Am I unmuted now?
There you go.
I believe I'm in 2 ways. Can you all hear me?
Yes.
You can. Okay, great. Thank you for your patience. So yes, I'll be brief here because I get to plug that in a couple of days we're to have a companion webinar that focuses on telehealth. And I'll just say that all of us that work in telehealth, especially in pediatrics, we really got into this business because we thought we would be improving access to telehealth. And we do believe that there's a lot of opportunities and potential there. And this is the time to act and to use it. And many of you all are using it. As you can see in an interesting way of showing the interest in telehealth, PubMed searches have just accelerated here on the graph in the past year. So what I will say, though, is we're definitely seeing disparities being exacerbated, just as Dr. Sanders had anticipated with his comments there. So I'm going to pass it back now and just offer that as a tease to our next session.
Thank you both. What we've described for you are patterns. And one of my colleagues who's a local health officer in Benton Harbor, Michigan, said this on a panel a couple of weeks ago. She said, what is patterned is predictable, and what is predictable is preventable. Now, she's an epidemiologist, so she thinks about numbers and data and patterns and predictions. But I agree. We've described a number of patterns for you. And I would say that sometimes we feel tired, that just the lack of certainty about what to do can be draining, right? And so what I want to do now is just sort of share some insights about how do we drive into that, that pattern of solution. And I want to just introduce or share with you or remind some of you of two seminal studies that really got us on this journey. And there was a lot of tug around what's our responsibility as providers, as health professionals, public health professionals. We wanted to really push that this was really more about personal responsibility, and people just needed to do what we told them to do. And we began to see studies, these in the, this one from the mid-90s, where we were seeing referral for procedures, right? This is a population that's sort of controlled for by age. They're all Medicare beneficiaries, so there's some consistency there. But when we looked at a number of procedures, angioplasty, coronary artery bypass graft surgery, CABG, mammograms, hip fracture repairs, amputation of a limb, we saw that that ratio was consistently from hip fractures and up, less than 1. Which means that Blacks were less likely to be referred, even though they likely needed the procedure. There were only 2 procedures where Blacks were more likely, by 3.5, 2.5 times more likely to be referred. And I would submit that those were the most egregious procedures, right? Amputation of all or part of a limb and bilateral orchiectomy. I'll let you go to your medical dictionary to look that one up. So we see these patterns, again, predictably happening. This study by Schulman et al. Was just sort of mind-blowing. It was a pure experiment where they took these 4 pictures, gave them to a bunch of docs, gave them descriptions of who they were, what the presenting symptoms were, and then they gave the exact same write-ups with these pictures. And what they found in this evidence peer-reviewed study was that Blacks were less likely, 40%, to be referred for cardiac catheterization, even though the write-up was the exact same, regardless of race. When they asked physicians about sort of the context of people's lives, the Blacks, even if they were Mrs. Jones as the teacher, Black Mrs. Jones as the teacher, white Mrs. Jones as the teacher, Blacks were always rated as having lower income. So race and sex clearly was affecting referral decisions, and it suggested that there was some bias, not suggesting whether it was subconscious or intentional or deliberate, but clearly something happening in the minds of the providers. And this pattern has simply continued. When you get these slides, you'll be able to look at them more carefully. Throughout the 2000s, we saw that. And even now, this year, we have 2 powerful studies, one that looked at glomerular filtration rate referrals and outcomes, others that was maternal child health, finding that racial concordance and discordance between the patient and the provider had a significant impact on the decision-making that providers were making, finding that using what would seem to be an objective algorithm to refer still carried with it bias. And when the same algorithm was used amongst Blacks that was used for whites, then 1/3 of Black patients, more than 700 people, would have been placed on in a more severe category of kidney disease, pushing them to the top for more care. So we're in the midst of a situation that we cannot deny. And so what's our responsibility? What is our responsibility, those of us who are leading equity now in systems of care. Martin Luther King again says, you have very little morally persuasive power with people who can feel your underlying contempt. You cannot fake it until you make it. Patients are smart and patients are experienced with our systems. This is another quote that I want to share with you. This patient with sickle cell disease says, my hematologist is getting older and we're talking about transition. I worry about getting a new doctor when he retires. I worry about them getting to know me and me feeling comfortable expressing how I'm feeling. I do not want to be judged because of the color of my skin or a precondition that I'm drug seeking. Now, you all know how painful sickle cell disease is. And to think that people have to think through, do I remain in pain or do I deal with the stereotype and being accused of something that I know is not true? So I want to offer to you a little strategy when you're faced with these situations in which you're asked your opinion or you're asked to lead. I want to suggest to you that there are several lenses you can think about. You can look at these scenarios from a lens of self or self and other, sort of interpersonally. You can look at these situations through a lens of culture. How is culture contributing to the problem that the families are having? You can look at it through a system of structure. Do we really require 15 minutes as the cutoff before people can have to reschedule their appointment? Is it a systems issue? If you begin to break down the circumstance through those lenses, it will propel you more quickly to the solution. And so I'm going to ask you guys to participate with me again. So get ready to type into your chat, right? Let's go back to that quote from the sickle cell patient who's worried about this transition, worried about getting a new doctor. Which lens would you suggest? Is this really about that patient? They're just over imagining the problem and why would they be worried? Should they be worried? Is this about the culture and the way providers interact with patients? Is it about the structure? Somebody says all. Yeah. So only you are the kind of the purveyor of which it is because you are planted into that system, right? So you might see, we talk sometimes about this thing called tone at the top. What's the leadership messages that, we better hurry up and get them in and get them out as quickly as we can? It's about volume. Is it excessively about what is the context, right, in that setting? So structure, and begin to think about what can we do differently? How do we onboard new providers? How do we help as a system advance the building of that relationship? So think through from that. So I love those. I think all is the winner. If we were doing this in a facilitated group, I might do then forced choice and say, which one would you go at first based upon what you think might be the catalytic decision? Let's go here because then that will have this beneficial effect on the subsequent. So thinking through, we're going to do a couple more of those. One of the things we find in our work is that people use the same words and mean completely different things. So when you're trying to lead equity, being able to say what you mean and mean what you say, build a shared vocabulary is really, really important. And I want to just leave you with, I want to give you 3 definitions to think about, because we also construct, if you Google Scholar even these terms, you are going to get multiple definitions. But again, based upon that culture, that structure, that system, who you are as a leader, it's important for you all to build a shared vocabulary. These just happen to be definitions that I built as shared vocabulary with my community, and they have held true for us. This one is actually one that Paula Braveman was from UCSF was asked by the Robert Wood Johnson Foundation to help them do just that. And I'm privileged to have sat on her committee, and we grappled with this, and we landed at this pretty simple definition, right? You can actually Google Braveman, Robert Wood Johnson, you see the citation down there, and there's a whole booklet that will come up. But we said that health equity means that everyone has a fair and just opportunity to be as healthy as possible. I mean, yeah, okay, yes. The challenge is in the details. So we said, yes, that is to the fair and just opportunity to be their healthiest selves. But if that's how we're defining equity, then this is also going to require us to remove obstacles to health, such as poverty, discrimination. Remember that walk to school, that walk in the neighborhood, those pictures I showed you, and not just dealing with poverty and discrimination directly, but as Dr. Sanders said, the indirect effects, things like powerlessness, lack of access to good jobs, lack of access to fair pay, to quality education, to safe housing, safe environments, health care. It's not good enough to just say, go get a job, go back to school, go find a house. It is those qualifiers that are vitally important. So if we talk about health equity, and many of us only want to talk about health equity because this is the hard stuff, health inequity, which is the context that we are in right now. I would submit that we see more inequity than we do see equity. So as you're leading equity now in your systems, push people to have those challenging conversations. And Margaret Whitehead has this definition, which I have just loved. She says that health inequity are differences in population health status and mortality rates that are systemic, they are patterned, they are unfair, they are unjust, and they are actionable, as opposed to random or caused by people who become ill. Now, remember when I said poverty and discrimination, people want to say there's nothing we can do about that. I can't fix racism. Oh, but we can. Those are socially constructed, and they can also be socially destructed. And I also love that Dr. Whitehead invited values to the table. Can we say that inequity is unfair? It is unjust. We should not stand for people living like this in our nation. And then social justice is sort of the aspirational, the absence of unfair, unjust advantage or privilege based upon race, class, gender, lots of other forms of difference. So think about what you are meaning when you say these words. What are you saying? What are you meaning? So let me just ask you again, if you are thinking about those definitions, what would that look like in action? What would we need to do in order for, in your system, those equity to begin to be observed? So type in a couple of more thoughts. What would it look like if you were sitting in a meeting, if you were walking past a conference room and you heard a conversation happening and you said, wow, that's equity happening in there? What might be going on? If you were doing grand rounds and hearing a presentation about some case and you said, ah, that's equity. Give me a few of those. See something, say something. Accountability, absolutely. Dismantling white supremacy structures. Now, I want to tell you to think deeply about what that looks like, right? What are the actions that are associated with dismantling white supremacy? Advocating for better conditions, yes, as it relates to social determinants of health. Not simply saying, well, that's not my job. I don't do that. I just see them within these four walls, right? Women speaking, giving voices, doctors asking patients directly about their expectation. This is about power, right? So yes, active listening to families, and then push yourself and say, what does active listening look like as opposed to passive listening? right? Especially now because we've got devices in the room too, and what does that all look like? So keep pushing yourself, challenging and thinking about what does it look like. So let me throw out these are some of my thoughts when I look at those definitions. So for me, if doing equity would look for it would be our seeking out what's unfair. Not just to say, oh, I found this thing, it's really not fair, but in order to reverse it or to avoid it. You know, the last time we did XYZ, patients had this problem, families had this challenge. We should be aspiring to apply justice. What does that look like? What decisions do we need to do? How do we recognize that social resources have an impact on the care and the behavior of the communities that we're serving? And how do we identify and facilitate opportunities? How do we take that so that they are readily and easily attaining well-being? How do we make the healthy choice the easy choice? Because you know it's not exactly these anymore. So I'm gonna read a couple of more quotes. I'm gonna read this one, and then we're gonna go and try to unpack one more. We're not gonna unpack both of these, but again, back to our lens. Which lens are we using? This is a mother of 2 children. This is the one. This is the one we did that I read initially and set in context. So where is the which lens is most helpful here? Right? Especially when you're not on Medicaid, traveling expenses, health insurance is covered, got to pay out of pocket, got to get gas, got to feed my kids, got to pick them up after school. That's the reality, right? That's real. So which lens would you apply to this? Systems and structure. Yeah. Systems hugely, right? Clearly, this woman does not have ready and easy access to care for her child. She's got to travel an hour. And so I bet some of those systems that are tertiary centers, high acuity centers, they recognize that patients are traveling from a long distance. How do we help them understand that that is an equity issue or an inequity issue based upon how we respond and set up care, structure care? Good. Here's one more. Pediatric provider. The mom of one of my patients is a waitress. If she's offered an extra shift, she's going to take it to support her family. And she may not know about those extra shifts until a week or 2 in advance of the appointment. So what happens? She's got to reschedule, then she's got to wait 3 weeks to get back in. And let's real quickly hit that one. What might be the lens that you can offer there? System, culture. Now it's interesting to me that y'all are, there's a self other. I'm like, are we completely removing ourselves from these scenarios? So think about, you're the leader, right? You're the leader in the system. So great, thank you. Great answers. Okay, let's get ready to close. I want to, as I mentioned, this is a journey, this leading equity, and you may risk being branded, right? You might be like, here they go, Renee's in the meeting, she's gonna say something. Yes, she is, yes, I am. So let me just give you some encouragement with a couple of travel tips. One, expect distrust and earn trust. Trust is earned, not given. And we so often, because of our positions, just assume that people are going to trust us, are going to open up to us. So position yourself. There's more reason for them to not trust us as parts of these systems. I once was blind, but now I see. May I implore that you throw away this myth of color blindness. Yes, we are beautifully, wonderfully made. We are unique and different. And somehow or another, we have been socialized to not see color. Well, I don't see you as a color. I see you as a person. Well, I'm a person whose color has really influenced my lived experience in this nation. Maybe in Nirvana one day, we won't have to see color, but we must. It's an opportunity to build relationship when we see color. It's uncomfortable. So just increase your comfort with discomfort. It's kind of like putting on those jeans after you get them out of the dryer or after they've hung dry. They are uncomfortable, but the longer you wear them, the more comfortable they are. You will make mistakes in dialoguing and facilitating dialogue around equity. But if you make that mistake, it will be a lasting lesson and you will be much better the next time. So take those risks. There is a saying that the road to hell is paved with good intentions. And I would submit that in this society, we like to emphasize that if we didn't mean to be racist, that we should get a pass. No, you are responsible for the outcomes of your actions, not just the intention, whether you meant to or not. And so push past wanting to ignore intention and deal with the consequences of our actions, both at the individual level, at the interpersonal, and at the system. If we see a policy is continually having a poor outcome, then we've got to advance and change it. Let me also invite you, this fairness oxymoron. We are again socialized in this society that fairness is sameness. Oh, no, I treat all my patients the same. Shame on you. Are all your patients the same? Do all your patients need the same thing? But again, we've been taught, no. I would submit that sometimes the most unfair thing you can do is to treat people the same, because they're not. So think also about your privilege. This sort of ironic, we think that as we climb the ladder that things should be easier. Actually, they should be harder, because to whom much is given, much is required. We have a lot to accomplish, and you're using your power and your privilege to advance change is critically important. There's a book by Eduardo Bonilla Silva that is entitled Racism Without Racist. I would submit you can really just get that term racist out of your vernacular. It stops dialogue, it advances change. Nobody wants to be called a racist, but again, if we're dealing with the outcomes and the consequences of people's actions, it pushes us to deal with the reality of perceptions, and even without using that word, can still advance dismantling systemic racism. This is all about a mindset. Are you doing this because you have to? Or are you doing this because you want to? And so let me invite you in one last point here that there's Lao Tzu has a quote that says, the journey of 1,000 miles begins with one step. So 1,001, take the first step. Throw into the chat for us, what might your first step be? What are you going to do? People are going to say, hey, I heard you did that NICHQ webinar. How was that? What are you going to tell them? What are you going to say? What are you going to do? The first thing, how will you begin to lead equity now in systems of care? Equity, not equality. Yeah. Self-reflection is so very important. You have to see yourself. You have to see yourself. What is going to be your first thing? I already texted a colleague, that they needed to be watching the webinar. Well, it will be recorded. Yeah. It's hard. You want to be your best self, so you've got to know kind of your worst self. Continue to call others in. Yes. Invite people to the table. I tell my team, we do the work in a way that keeps people whole and keeps people at the table, because privilege causes people to walk away. So let's get ready to close. Let me just finish Martin Luther King's quote for you, the one about the audacity. He concludes that by saying, and I believe that what self-centered people have torn down, people who are other-centered can build up. And I believe that you are those other-centered people because you logged into this webinar. And so I want to thank you for being sort of deputized as part of the force that is going to drive change in this nation, through your states, through your counties, through your jurisdiction, through your system in which you work, through the families and friends that you love, we do have a light at the end of this tunnel. So let's go. Oh, I'm sorry.
Well, Dr. Kennedy, I don't want to interrupt you, but this is Judy Gooding again,
Yes.
and we have a few minutes to look at some questions. Would you like to talk about questions a little bit before we go to the next slide?
Y'all saw me rushing right through.
Thank you. Well, and you know, we didn't expect you to be keeping up with all the questions while they were going on. So I just want to call a couple to your attention that I noted, and I'm sure that others on our team might find some more. One that was asked by Taryn. She says, "I'm a Caucasian health provider. How can I overcome the status or stats of bias between myself and my patients of a different race?" I wonder if you could comment on that.
Yeah, building authentic relationship across difference. May I offer first that you consider using the term white as opposed to Caucasian. Do some reading about that, right? Caucasian as a term came up when we were saying Negroid, Mongoloid, Caucasoid, and the Caucasus Pure Mountains and those types of things. And people have sometimes, actually young kids have said, why do they get to be Caucasian? Like, why do they have a fancy name and we're just Black? So there are these subtle things, right? On how are we making a difference? So see color. Allow yourself to see color. Ask people about, you know, how did you spend your Thanksgiving? Be transparent. Oh, we do something similar to that, but we shape it this way. So as you begin to build relationship and see color as opposed to being colorblind, then you begin to earn trust. You begin to build authentic relationship, and you begin to avoid some of those clinical outcomes like we saw in the studies that I was sharing. Judy, I don't know if you see, do you see this question from Kathy Gates? I see it popped up. Can I jump to that?
Sure, you absolutely can jump.
I want to jump to that one because Kathy is saying, why are our Indigenous people forgotten? For example, COVID is rampant in Navajo Nation. Why? Partially because a large number of families have no access to running water. How do we expect a population to practice good hygiene during a pandemic when they don't have running water? That is such a vitally important conversation. And I just had this conversation earlier on another topic. One, from an epidemiological perspective, so often Indigenous people get categorized as white, and we lose the depth of the need. I would submit that in Indian nations that in those sovereign states that have lots of capacity, have had members of their tribe go out, get these degrees, come back. They are the demonstration, the example for how to build trust, governmental trust, right? Because we know tribes are sovereign nations. And so how do we begin to continue to be, you're gonna have to be the excuse me but person. And those of you who have privilege, who may not be a member of the Indigenous community, when you speak up and say, have we asked about, why aren't we including? Right now we use the inexcusable answer of, well, the numbers are too small. Well, you know, demographically and statistically, it's not valid. We're not talking about a statistic, we're talking about lives and families. And so it just requires us to push the narrative differently. So there are increasing numbers of people who are recognizing just the points that you're making, Kathy. And that is what leading equity in our systems would be about. This would be an example of an action.
Thank you for jumping in with that, Dr. Kennedy. Another question that came up that I thought perhaps all of our participants, all of our speakers could contribute to is that systems, we were talking about systems being an issue, or actually individual self and others being one of the key factors. And one of the panelists, one of the participants wrote that that really their systems can be behind, and if I'm paraphrasing, systems can be behind some of the self-other as well. So for example, if a system has to change, that requires asking other providers to work irregular or hours that don't work for their families too. And how do you balance that? Or is that a balance that needs to be struck at all?
No, that's an excellent point. We talk about inward facing and outward facing policies. And so, for example, when we established our core values at NPHI, one of them is health equity and social justice. So what does it mean for us to apply health equity and social justice with our team, our employees, our NPHI family? And what does it look like for us to employ health equity, social justice for the clients and the partners that we're serving and helping? And so I think, yes, it is both and, right? It's pushing to say, have we also thought about, and I would submit that sometimes in health care systems, we tend to relegate this to HR. And I would submit that this is more about culture. There's a quote that says, culture eats strategy for lunch. So if you really, if you have an executive team that really wants to be successful, they need to focus on the culture, the internal culture of their organization. And that impacts how effective the team can be and their employees can be. Kind of a little tiny answer, but just an affirming yes, that does need to be done.
That's terrific. Thank you very much. And we do have a question for all panelists, but we don't have quite time for it. And I also think the panelists are going to want to give this some thought. So we'll be sure that we include it in our written response. And that is one about recommending toolkits or other, other materials, documents that give clinicians concrete ideas, skills, and techniques to identify and reduce their own implicit bias. So we will make sure that that falls onto our Q&A document or article that we provide to you all after this webinar.
And let me just throw out one caution with tools. Like in public health, we love toolkits. Give me the toolkit. But they don't always, you have to decide what's the best toolkit. Let me just give you a quick example. As an African-American woman who wears her hair natural, people are like, what do you use on your hair? What do you use on your hair? Well, I've gone after products that made my friend's hair look wonderful and made my hair look like straw. So you have to really, there's no one size fits all. You have to do that assessment. There's this question about policy. Sometimes it's not about a bad policy. Sometimes it's more about bad people, if I can dare say that. It is the people who are executing on the policy that are the problem, not the policy itself. So you've got to think in a sort of bi-directional way. And you're throwing out your feelings.
There you go.
Thank you. This smart group, smart group. So we were hoping to land you at a place of sort of affectively slightly different, right? Feeling empowered, feeling encouraged, feeling hopeful, feeling motivated, challenged, but also willing to step in. And I'm just looking forward to 5 to 10 years from now, the growth that we will have made together. I absolutely believe it will happen. Otherwise, I would not be wasting my time. Thank you, guys. And thank you, NICHQ. Thank you, Judy, so very much.
Judy, I think you're on mute.
Shucks.
Oh, I think you're still on mute.
This is Judy Gooding back.
There we go.
Off mute. And I want to express my gratitude and appreciation to all of our speakers, first to Dr. Kennedy and also to Dr. Sanders and Dr. McElligott for joining us today. And I want to have a couple of closing notes, and I want to ask you that while I'm going through those, you begin to take take a moment right now to use the QR code to access a few post-webinar questions for us. We would really appreciate this feedback and would love to hear from you. Your questions and comments, as I said before, will be addressed in an article that NICHQ is going to develop with our faculty and make available to you and likely also on our website. And this webinar has been recorded and will be posted on our website for you to share with your colleagues, and we hope you do that. Another plug for the next webinar in this series, please join us Thursday, December 3rd. That's this week, for the second of this two-part series, Pediatric Telehealth Strategies During and Post, the COVID-19 Pandemic. This will be featuring Dr. Jimmy McElligott, that you heard from, whom you heard from a little bit today, and he'll be joined by Dr. Sanders, who you also heard from today. This webinar too has been greatly enhanced by Dr. Kennedy and her expertise. So again, I want to thank our speakers, and I want to thank all of you for joining us today, and I hope to see you again soon.